So welcome everybody. I can see lots of people are joining the meeting. So we'll start in a couple of minutes, but thank you all very much for joining us this afternoon. We're not quite at start time, so we'll give it a minute or two more before we get going. We've had about 230, I think, people registering for this webinar this afternoon. While perhaps not everybody will be able to make it, I think that's a great number of people. So thanks ever so much for getting involved. Great. Well, we've reached 100 participants and rising, and it's now 3:30. So I think it's time to do, while a few more people join us, it's time to do a more formal welcome this afternoon. I hope you're all here for a question time on COVID-19 and dialysis. I think that we have quite a few people with kidney disease and perhaps some healthcare professionals have joined us this afternoon as well. But wherever you are, thanks a lot for joining. You can see on the left-hand side of your screen there that if you're on Twitter, we're going to be tweeting using the hashtag COVID question time. If you're not a Twitterer or tweeter, don't worry about it. It's just we're going to be sharing with people that we are running this event this afternoon. So while that happens, I'm going to ask Julie to move on to the next screen and talk a little bit about how we're going to be running this afternoon's question time session. So if you wiggle around your mouse, at the bottom of the screen, you'll be able to see some things. And one says the numbers of people part of the meeting, so it's 112 at the moment. One says Q&A and one says chat. So as we run through this afternoon, please feel free to ask your own questions by clicking into the Q&A and typing questions in. And then if anyone else likes those questions, you can click on the thumbs up next to the question to say, I'd like to hear the answer to that question. Hopefully we'll be answering many of the questions that you kindly put in during the session anyway. If you have any technical issues, next to the Q&A at the bottom of your screen, you'll be able to see something called chat. So you can click into that. And if it's things like, you can't hear properly or something, you want that kind of support, please put those on there. And we'll try and separate the technical questions to the chat box and the questions about what we're talking about this afternoon to the Q&A. So we're recording the meeting. You can probably see that if you look up at the top left-hand side. So it'll be available afterwards for people to listen back to. What I'd like to do now then is introduce you to everybody who's behind and helping to run the webinar this afternoon. So I'm very grateful that we have the support of a number of colleagues, both at Kidney Care UK, at the Renal Association, British Renal Society, and the Association of Nephrology Nurses for this event. So we've got Dr. Andrew Frankel, who's a kidney doctor at Imperial Healthcare, who will be speaking, one of your panelists. We've got consultant nurse Karen Jenkins, who's from Kent and Canterbury Hospital, who is also speaking this afternoon, answering some of your questions. And in the background, you may see a range of names. So these are other people who will be able to feed in and who are helping us. So Dr. Rebecca Suckling, who's kidney doctor from Epsom St Helier Hospital, Julie Slevin from the Renal Association, who's doing some of the technical support and working the slides. And then my colleagues, Sharon Woodward, running from comms, Sam Sharp from policy team, and Mel also helping us with technical support from Kidney Care UK. So without further ado then, I think we'd like to go on to the next slide. And I'll explain how we're going to work it this afternoon. So you've sent us lots and lots of questions about different things to do with dialysis and COVID. And what we've done is we've gone through them all, and thanks again for sending them to us. And what we've gone through them all and split them up into sort of 8 main areas. And we've nominated one of those experts, so either Karen or Andrew, to respond, and they're going to then comment on a range of things under each topic that will reflect some of the questions that you've asked. So you may well recognise some of the questions that you've asked in there. We're not able to answer very specific personal questions, as we said before, but these are general questions that we hope will help you with a bit of education and some vital information. I should have introduced myself as well. I realise I forgot to do that. So my name is Fiona Loud. I'm Policy Director for Kidney Care UK, and I'm also somebody who has had kidney failure too. So I spent 5 years on dialysis, and I've had a transplant for the last 13 years, kidney from my husband. Right, so let's get going. So first of all, I'd like to invite Andrew to unmute himself and to talk to us a bit about how COVID impacts the kidneys and in what way. So Andrew, over to you, please.
Thank you very much. First of all, thank you, Fiona, for inviting me, and to all those out there, thank you for attending today. So I want to try and keep the answer as succinct as possible, because we'll have, I suspect, more questions about this as we go along. COVID and the kidney has really, if you're thinking about it, there's two different directions to think about. Firstly, if you have kidney disease, does that influence your response to a COVID infection? And the answer to that is yes, it does. People with chronic kidney disease are more likely to get iller if they acquire COVID-19. That is particularly true if you are on hemodialysis. So kidney disease itself means that you will be at greater risk from COVID-19. I would also like to mention the other side of the coin, which is that we think that people who have got no kidney disease or people with stable kidney function, COVID can cause a deterioration in kidney function, acute kidney injury, and there may or may not be long-term effects of COVID-19 on the kidney that we're currently looking into and researching. So that's how COVID and the kidney interact. But I want to say something more about the risk, and I think this is going to be a general comment that will pervade through the rest of the session. When we talk about increased risk, there are factors that we know are associated with a greater risk of either acquiring, or if acquiring, getting more severe infection. And they include things that you probably heard about in the press. Men more than women, certain ethnicities, Black, Afro-Caribbean, particularly, Asian, particularly as well. The presence of obesity, the presence of diabetes, the presence and degree of chronic kidney disease. These are just a couple, or a few. But what you need to understand is that that increased risk doesn't mean you'll suddenly go, everyone who has one of those attributes is suddenly in high risk. It isn't like that. The increased risk that is associated with these is dependent on the degree of some of these attributes. So you could, for instance, be a young Afro-Caribbean male with moderate chronic kidney disease, no other problems, not obese, and your increased risk will be there, but it won't be as much as, say, a Caucasian patient who's on dialysis with diabetes and cardiovascular disease. So you really do need to individualize your risk, and you may need to try and get a better understanding of that by discussion with your healthcare worker, your consultant, your dialysis nurse, to really understand what risk you have. I just want to put that out there so people don't think risk is just a single increase in effect.
Thank you, Andrew. That's great as a starter, because I know that we've had a number of questions for people about, well, how will this affect me? And I guess we'll be able to explore a little bit more about some of the specific aspects as we go through this afternoon. But I think your key message there is about personal advice, of course. So what we're going to now do is, Julie, if you could just press on the slide, please. So then we have a further question, which may or may not come up on the screen, but I'm sure it will shortly. And we've been asked, and what I should say, by the way, just to acknowledge, our first questions come up in the Q&A. Keith has asked, somebody has asked about antibody testing. We're having there's a question set later on about antibody testing. And I should also have mentioned, we've had a lot of questions about shielding, going back to school, and about employment, and we're covering those a bit later in the session. So back to this question. So this is really a question about about keeping safe in the community. We've got another one in a minute about keeping safe in hospital. So this is really about what can we do as people on dialysis to keep safe in the community, and the kind of perhaps a little bit of a discussion of the risks dialysis patients experience daily. So I'd like to hand over to Karen, consultant nurse Karen from Kent and Canterbury, to start to answer that question about what we can do to keep safe in the community. Karen.
Thank you very much, Fiona. I think some of the key things are really what's out there for everybody, and some of the key messages that are coming from the government about washing your hands, covering your face in public places, making space, keeping at least 2 meters apart where you can. And I know there are badges and lanyards available which actually state that we be more mindful of social distancing, but also we have our own responsibility to make sure that we're keeping away from other people. So I think it's very much a partnership approach, really. I think trying to avoid to be face-to-face with people outside of your household, not trying to be in too close contact with anybody, and sort of trying to remain in your own support bubbles that you probably have created for yourselves. If you are indoors, keep the environment well ventilated, and try and avoid crowded spaces. I know with more and more people coming out at the moment, it is quite difficult at times. Small things like washing your clothes regularly, perhaps if you've been out, been travelling, or even coming in and out of dialysis, washing your clothes when you get home. And also, if you are going out more, because more people are wanting to potentially socialise, is thinking about participating in the sort of track and trace and track and testing areas, really. I think think about where you're going to be going. Is the environment you're going to be deemed as being COVID secure? Lots of things being put in place in public places. Think about where you're going. Why do you actually need to go there? Thinking about the rules about socialising indoors in groups of perhaps not more than 2 households, being outside. Thinking of gatherings larger than 6 people probably isn't really not a good idea. Some of these, I suppose, restrictions might depend where you live, so it might be slightly different in Scotland, Wales, Northern Ireland and England, so it's being aware of what's available locally, and sometimes there are local restrictions in place as well. And thinking carefully, people might want to visit relatives. Are you able to stay overnight? Is that a really good idea? Perhaps you shouldn't be with anybody else outside of your bubble or with anybody else from another household. And trying to really maintain social distancing as much as possible. I think is some of the key things, which is it's a generalisation, but something to be even more aware of if you're feeling vulnerable.
Thank you, Karen. There was a particular question, I don't know if you'd be able to respond to it, but it's about can I hug my mum who has CKD stage 5?
Yeah, I think we'd all love to be able to hug our mum, and I think if you're in the same bubble and you've created that bubble with yourself, that's probably quite safe. But it's actually thinking about the risk and who else have you been in contact with before you hug your mum. So you're not coming from a different environment, making sure you wash your hands, making sure that everything is clean around you. So I'm not going to say don't hug each other, but just hug each other carefully, probably.
Thank you. And also you mentioned track and trace. Is there anything that you can let us know about that at the moment? Because there's a track and trace system on at the moment, isn't there? And so if anyone was in touch with somebody who happened to have COVID symptoms, you could still be contacted, couldn't you?
Yes.
About that. So perhaps you could just...
That's right. I think if you're going to places, most places publicly now are asking people to give their name, address and telephone number. I think it's important to be able to participate in that. So if somebody has reported symptoms, that they would be able to contact you had you been in that environment. So that is available at the moment. And I think it's almost becoming the norm that whenever you go somewhere publicly that you know, you're asked your details, it just becomes an automatic response. Yes, this is my telephone number, etc. So that you can be contacted if you're at risk.
What a rookie mistake! I muted myself. Thanks ever so much, and don't forget to keep asking your questions in the Q&A if you want to ask about any of the things we're talking about this afternoon. Julie, can you click on please to the next one? This one's also for Karen. We had quite a lot of questions about what units are doing to keep dialysis patients safe during the outbreak. And first, I mean, the first question really is it safe to have dialysis in hospital at the moment?
Thanks, Fiona. Yeah, I mean, I think what renal units are doing is actually looking at how they can possibly minimise the risk of any transmission of COVID-19, particularly in haemodialysis units and in hospitals in general. So lots of things are being put in place. We're lucky to have some sort of national recommendations available for people, particularly in dialysis units, which are out there for units to have as a bit of guidance. I think there are measures being put in place in the dialysis units around enhanced cleaning, having social distancing measures where possible, particularly in waiting areas, and reducing the amount of, I suppose, traffic going through those waiting areas, and perhaps giving people appointment times and staggering times around dialysis from that point of view. I think you might notice that if you're going into hospitals and into perhaps dialysis units, there may be other measures. You might see screens up, you might see that there's machines might have been moved, there might be tape on the floor, all this kind of thing, which is enhancing the social distancing. Staff are doing whatever they possibly can to protect patients, and also, I think, to protect themselves. So you will be seeing more staff wearing personal protective equipment, particularly gloves, masks, visors and aprons. For patients that have been identified or are potentially suspected of having COVID, those patients will be isolated, and the nursing staff would wear more enhanced personal protective equipment, such as gowns, as well as the gloves and the aprons and the masks and the visors. I think it's very much around looking at the environment. Different units might do things in different ways, but there's some basic standard practice. Some of you probably have seen lots of people wearing masks on dialysis, people travelling wearing masks. This is being encouraged. But of course, we do have to be respectful and mindful that some people may not be able to wear a mask, and there could be a reason that you might be sitting in a dialysis unit with somebody who is nearby who's not wearing the mask, and it may be that they're not able to. So we need to be able to understand that. I think from, I suppose, as a person coming in for dialysis, making sure you're washing your hands. If you're touching anything, you wash your hands. If you're eating and drinking dialysis, then to particularly sanitise your hands in between doing anything else that you may have touched from that point of view. I think all hospitals now, or trusts now, have defined processes for screening and swabbing for COVID-19 and isolation procedures. That may differ, but the standards would be the same if you're in a centre unit, dialysis unit, a satellite unit, even a private provider unit. We would expect the standards to be pretty much the same. As an inpatient, there may be different approaches. Obviously, visiting is limited, and that will be up to each individual trust how that is put in place. And if people may need to have dialysis on the ward, they may need to be moved into a separate area. So it's very much around keeping everything as clean as possible, protecting the people that are coming in and out, and also for the staff to take as many precautions as possible, and they've all had enhanced education and training for that.
Thank you, Karen. A question's just come up actually, which we can perhaps answer at the moment, from Keith. As we are vulnerable, would it be better for us to wear FFP3 or N95 masks rather than just a regular standard mask or a cloth mask?
I think there's been a lot of discussion about the types of masks to wear. So the FFP3 masks are really for what was been through sort of aerosol generating procedures, and they're really for if actually somebody's going to be having a specific procedure, and that the staff would be wearing those just for those specific procedures. I think there's the guidance. It doesn't sort of say that you should be wearing those types of masks. They're saying that a waterproof, water-resistant mask is adequate, really, if you're coming into hospital. And most hospitals now, as you're coming in the door, you may find you're having your own temperature taken and being given one of these masks as you walk into the hospital.
Great. Okay. Thank you for answering that one. And then there was a final thing probably in this section, which was what should people do if they observe perhaps ambulance drivers or something perhaps not adhering to the guidance that you've so helpfully laid out for everybody as to what to expect when people come in and out of dialysis units, whether they're in hospital or at a satellite.
Yeah, of course. I mean, I think it should certainly raise their concerns to the staff in the unit, the nursing staff in the unit. I mean, you could feel that you might want to ask the person themselves, but it's probably more comfortable if you mention it to the nursing staff, because I think there are procedures in place. You may see that your ambulance drivers are wearing the PPE. They may be coming in and out to collect somebody, then we might have to ask them to wait outside. So I think you'd certainly alert it to the nurse in charge or the nurses in the unit to be able to help you deal with that.
Lovely. Okay, thank you. And I can see we're getting more questions, but a few questions have gone on into the chat. So if it's possible for people to put the questions for the session in the Q&A and save the chat for any technical questions, that would be great. And then we can see them more easily and answer them. So that's just to everybody, all 155 of you on the call at the moment. And there's another question, Karen, just before we move over to Andrew for the next one, which is about concerns about people where there perhaps isn't easy to keep a safe distance in a waiting area, because a lot of our units were designed quite a long time ago, and they certainly weren't designed to have huge waiting areas. So any thoughts about what we can do there?
I think where possible units are, I think I've seen a lot of units have removed chairs from the seating area, so there's more social distancing, but actually trying not to have people in the waiting area. So perhaps staggering start times, coming in for dialysis, transport times, and asking people perhaps to wait in the unit until, if they're going by transport, their driver arrives and then they can go straight out and into the vehicle. Perhaps sometimes waiting in the vehicle till the sort of in and out is clear for somebody to come through. I mean, it would be ideal if we could have separate entrance and exits, but that's not always possible with some of the geography and the environment. I think it's trying to avoid any sort of congestion in waiting areas is the key thing there, really.
Right. Okay. Thanks very much indeed. I think if we could move on, Julie, just with one more on here. The next question we thought would be good for Andrew. So we had a question about changes to dialysis sessions. People remember that some people were asked to go on to twice a week dialysis, particularly when the pandemic was at its height a couple of months ago. And so I wonder if Andrew could comment about how it can be in dialysis patients' best interest to reduce dialysis hours and what the implications might be of reduced dialysis per session for people.
So there are two aspects to changing dialysis schedules. The first related to the fact that many units needed to create COVID-19 dialysis areas and therefore needed to move people who didn't have COVID to different dialysis shifts or units. And that, I have to say, was essential, particularly at the peak of the COVID-19 pandemic, and I hope we won't ever go back to anything like that. And I want to pay tribute to all of the patients, because I do know at Imperial we did a huge amount of movement, and patients were fantastic in their flexibility in moving from one centre to the other or one shift to the other during that crisis, and that freed up space so we could cohort patients with COVID-19. At the same time, there was also the feeling that we would need to create some flexibility in the system, and that moving some patients to twice weekly dialysis may be helpful both for the unit but also for the patient, because it would reduce contact with other dialysis patients. But I want to be clear, this policy, when it was developed, was designed predominantly for people who had recently started dialysis, who had residual kidney function, in whom it would be perfectly acceptable to convert to twice weekly dialysis. And indeed, some units are now moving to a situation where someone who starts dialysis from the advanced kidney care service initially starts on 4x4, 2x4 dialysis sessions, and increments as their residual function decreases. So it was really designed to only be undertaken for those group of patients in whom you could do that with minimal risk to them and yet reduce the burden that they would have in terms of contact with other patients, as well as providing some flexibility in dialysis, not as a general rule.
Thanks. And am I right in saying that that has now stopped in all or most units?
I think that the only time that people are being asked to do twice a weekly dialysis is where they have residual function and it's in their interest, and the unit is actually undertaking what we call this incremental, this slowly increasing start to dialysis. I don't think we had anything like the same crisis we had in March and April and early May that required some units to do this.
Let's hope we don't go back to that situation.
Absolutely.
I truly hope, hope so. Now, there's a few questions that have come up on the Q&A, so which thank you. Some of them we'll be able to address later in this session. There's some things about going back to work, and there's some things about the end of shielding and things like that. So we will definitely be going back to those shortly. So if you hold on, we'll come back. We'll come back to that. And right. Let's now move on to the next slide, please. And then once more, please. So this session, we've had a few questions actually, and some of these may well relate to the one we were just discussing. But this one is going to kick off. It's for Andrew to start with, and this is about the fact that we know that a lot of healthcare was paused, was suspended during the pandemic. Or during the peak of the pandemic, and people have been asking about when are things going to get a bit more back to normal. So when am I going to be seen again? When am I going to be seen face to face in clinic and so forth? And so somebody has asked the question about why my next nephrology appointment is going to still be quite a long way in the future. And perhaps you could just talk a little bit about what the plans are. And this particular one was about a telephone consultation only as well. So perhaps you could talk about how we're going to.
So one of the things that we've tried to do is to reduce the risk to patients that you will get by coming up to an outpatient clinic where you would be mixing with a number of other patients. And outpatient services therefore stopped most face-to-face appointments. The other side of the coin there was we suddenly realized that we don't actually always need to see a patient sitting in front of us to do an effective consultation. And we are doing much more of our medicine now by video, by telephone, but particularly video. And I think that we've recognized that this offers advantages for patients and for the health service. And many, many consultations in the future are now going to be undertaken by video where that is appropriate. Where it is not appropriate, and for my clinic, we have a choice. We go through all the patients, and patients are offered video if we feel that that's reasonable for them and will provide them with what they need. But we also bring patients in to a completely different environment of our outpatients, much reduced in terms of patients numbered, much more ordered and orderly, so we can do that safely. So things are going to take several months to return back to a normal, but the new normal will not be the same as we had before, because we'll be doing a lot more of that remotely, but you should feel that you are still getting the attention you need by whichever medium is used to undertake that consultation with you.
So can I just confirm, we were talking about this for some of the advocacy officers earlier today, some of the Kidney Care UK advocacy officers. People will still have a choice, though. They'll still very much be given the choice. If they want to come in and be seen face to face, they can do that.
Well, the answer to that is an interesting one, Fiona. I don't think at the moment people are getting that choice because there's so many patients and so many appointments, and the administration around this is so huge, it's quite difficult. I think that we need to consider how that's going to work in the transplant world, in the CKD world, but of course in the dialysis world, people are coming onto dialysis units, and therefore they are getting the chance to have face-to-face consultations. How it will affect home hemodialysis patients and PD patients, that needs to be sorted out. And in my mind, given the patient numbers, we should be able to give these patients some choice. We just need to deal with the administrative burden. And I really won't bore you with how that works from my end and our outpatient manager's end, but to ask every patient who's attending a clinic what they what they would prefer, and then creating the slot and putting them in the slot and making sure they're in the right slot is actually quite a difficult undertaking. I have to say that if a patient who is given a virtual and tells me, I ask them if they're happy with the consultation, generally people are. They're happy not to come to hospital. But if they say they would like to see me face to face, I always organise that.
Thank you. And I think for future events, we should do a poll of our audience to actually hear what people are undergoing as we ask them these questions, because I think that'd be really interesting. Can I just sneak another question in there, please? And somebody's on dialysis, is it safe to have a transplant now, or should they stay on dialysis?
This comes back to risk. Initially, we stopped all transplantation. We didn't know how this would be affected by COVID. We do know people who have a transplant require a lot of immunosuppression initially and have to come in and out of hospital. So they would be at great risk. That environment isn't there anymore, and most units have now, and I think almost all units have now opened up their transplant service again. They're doing it in a risk manner. So they are gradually expanding the deceased donor list on the basis of the risk to that patient. So if you are likely to need augmented lots of immunosuppression compared to someone who just needs standard immunosuppression, and if you are likely to have a more complex operation because you are more obese or various other factors, you may be held back before activation until we are a little bit more secure. But if your risk, and this is why I said at the beginning, the risk isn't just binary, it isn't just yes or no, it's individualized. If, however, your risk is reasonably low, that is, you are a standard CKD patient, you've got no cardiovascular morbid problems, and you can have a straightforward transplant, actually the benefits for you of having a transplant over going on dialysis are significant. And if you are offered the opportunity to go back on the list, you should consider taking it. But what you need to do, this is the key, is to have that discussion with your nephrologist or your advanced kidney care nurse and say, is this appropriate for me to go back on the list? And if a kidney was offered to me tomorrow, would it be safe for me to accept it? I think for most people, we are moving back to saying yes, but there will be a few who may need to be a bit more cautious and wait a little bit longer.
Thanks. Thank you. Lots to think about there. And the second half of this question, just by the way, we're about halfway through the session now, just so people know in terms of what's going on. But we may well have a short piece at the end. As we said, we may run on another few minutes in order to answer the questions. So on the theme of access to healthcare, I'd like to ask Karen a few questions, if I may. So the first one is, it's from somebody who's on home hemo, and it's about whether community dialysis nurses should continue to visit to take blood samples, and whether any of those practices might be changing or stay as they are.
Okay, thanks, Fiona. I think obviously practices are going to vary across the country and in different units to what's the norm. So I think I don't know, there's various things in place. So some patients on home hemodialysis will take their own blood samples, and they may be collected by courier and taken into the hospital. And some patients may be visited regularly by their home dialysis teams. There's no reason why things should change from the home visits. It might be that the nurses are wearing they will be wearing personal protective clothing if they're going into somebody's house to take those samples. But I think during the COVID period, a lot more remote monitoring was introduced initially, so that people could still communicate. I think the key thing was that people on home dialysis didn't feel isolated. And although they may, during that period of time, not have had visits from their nurses into the community, they would be able to communicate them either by telephone, telemedicine, or whatever the unit could be able to put in place. And I think it's important that we try and, I guess, return to as many of our usual practices that we possibly can. But it's also, again, I think about the safety. And actually, if the nurses are going to have to visit multiple patients, it's around how they do that without moving from one place to another. So I think that's going to be very much on the individual unit and how they normally practice, and they may want to review their practices. I can't see that anyone would stop visiting at home completely, but they may reduce their schedule, or they may look at things, doing things maybe slightly differently, obviously in partnership with the patients themselves.
Thanks. That's great. That's really helpful. And actually, sort of on the same theme of home dialysis, so applies to PD as well as the about to start dialysis. Would you advise them to look at home therapies at this time? I know obviously all choices are still there, but what would you say to them about perhaps considering dialysing at home, where perhaps there's less risk of infection than dialysing in unit? What would be your thoughts there?
Yeah, I can see with you're thinking about the benefits of not coming into hospital to have the treatment. But I think when anyone's considering home dialysis, there's an element of training involved in that as well, and somebody being comfortable to dialyse on their own at home. So some units may need the people to come into to train for home dialysis, and some may be able to be provided in their own home. I can't see any reason why we should not continue with promotion of home dialysis as we normally are. But again, I think it's about the risk factors, thinking about, is it safe for that person to dialyse at home? Have they got enough? Are they confident enough to do that? Do they need, what extra support might they need to be able to dialyse at home safely? So I think it's very much that partnership. Andrew?
Yeah, I completely agree with everything that Karen has said. We do know, however, that the incidence of infection in people who are established on home dialysis, particularly PD and home hemodialysis, was significantly less, the rate of infection, than people in hospital hemodialysis. And I think that just enters the discussion you have with your consultant or advanced kidney care nurse when you are considering your option for what treatment you are going to have at end-stage renal failure. And we revisited many people who are approaching end stage and threw this into the mix. Some then changed their mind and moved to a home option. Some continued with their plans for hospital. But you do need to throw that into the mix.
Yeah, thanks. That's great. So Julie, could you click on, please? And we've got two fairly large topics to look at. So one is about going back to school, and the other one is about going back to work, which also talks quite a lot about the pausing and shielding. So let's ask Karen to start to address something we had a lot of questions about. So it could be summarised really as, is it safe for children of kidney patients to return to school, and what can be done to reduce the risk of doing so? And we've got lots of different examples of mums and dads worrying about that. For people on dialysis.
That's a fabulous question, Fiona. Thank you. So I think there's not one simple answer to this, of course. I mean, obviously, we've looked at children gradually going back to school, and we know from the 1st of September, looking at children of all ages going back to school. I think one of the key things really, if it's your children are going back to school, is for you to have the discussion with the school or the college to see what measures they're putting in place to reduce risk, and that should be in line with local government guidance. And I think the schools will also have a duty to ensure that everyone's doing the hand washing, looking at social distancing, having the ability to have the hand sanitisers, etc. Enhanced cleaning, all those sorts of things. For the younger children, I think they've been in bubbles, and that looks like that is going to continue. So you would expect your child to be in a bubble with a certain amount of pupils, and they would be being taught in that bubble. They'd have playtimes together, etc. I would imagine the concern is about going to and from school to pick your children up. I think again that's around making sure you've got face coverings, making sure you're washing your hands, making sure that the children washing their hands, so they come home from school, they change their clothes straight away, have a shower, have a bath, whatever, so that you're keeping the hygiene up as much as possible. The government has got extensive guidance for schools and of different ages, and it may be they're staggering the start times and the finish times as well. So I think there's a lot out there that hopefully will support people and reassure people that schools are doing all the best they can. But I think it's important, if you have concerns, to have a discussion with the school, your own individual school, to see what they're putting in place, and if there's any adjustments you might need to make, you have that partnership with the school.
So would you advise people to be having those conversations now with the schools? In fact, schools have already gone back in Scotland. Perhaps perhaps I'm probably asking the wrong person because you're not based anywhere. You're not based in Scotland, you're based in Kent.
I have a nephew who's gone back to school in Scotland, actually.
So have we heard anything back from people in Scotland about any of those issues? Because I mean, there's quite a lot in there for parents to think about, isn't there?
Yeah, I think everyone's very nervous about how it would be, but I think that they can see that I think if you can visibly see there are things in place, that gives that sort of degree of reassurance that actually the children are washing their hands. They are coming in and out at different times, and the children are reporting that they're staying within their groups. So I think it's getting the feedback from the children as well as what's happening.
Yeah, and maybe could you just perhaps comment a little bit about, and there was a particular question which perhaps summarised it quite well, about any specific measures that I'll be put in place about bubbling, about children going to these bubbles, and whether is that something that is going to apply to all schools, do we think, or is it just up to the local head and the local authority?
I think it's something that's been recommended for all schools for the younger children. I don't know that, I think the older children it's probably slightly different, but I think it is being encouraged with the younger children because they're more inclined to be able, the way they are mixing and not perhaps being so aware that they're keeping within their bubbles. I think with the older children, then there's more of a discussion around the social distancing, and having more of a conversation, perhaps with the sort of teenagers, I suppose, but they do tend to congregate. So I think it's about sort of keeping it about social distancing and trying to social distance in the classrooms as well, which I think is probably a challenge. And maybe they're looking at reducing some of the time that children are in school potentially, or the looking at the environment.
Okay. Thank you. Yeah, it's an anxious time for people. I'm just looking through all the questions there, and you've addressed quite a lot of them. And it's just really about, on balance, do we think it's safe to return for children to return to school? And I think you're saying on balance it is, accepting that is a bit of work for patients to think about and work on. And there was just one other one about, will fines be reintroduced for non-attendance at school by the local authorities?
Yes, they will. But however, if for any reason children are not able to attend school, if parents are following clinical or public health advice, then that absence will not be penalised. So if there is for an absolutely valid medical reason, then a fine would not be invoked. So. Thank
you. And we've just got one that's come up live, and so if you want to answer it later, that's fine. But do you have any advice for teachers on dialysis?
Yeah, I think it's probably about protecting yourselves as well as your pupils, isn't it? And taking the precautions yourselves, and I think being mindful about the distancing, and perhaps maybe I guess it might come under the returning to work as well, to see what's being put in place by the school, and generally, and different measures. So I think we might cover some of that in returning to work. It might come under that.
Yeah. Okay, lovely. Thank you very much. And I think, as advertised, the returning to work will be is now where we're going to move on to. And Andrew has the delightful role of leading on this one. And we have had, and we continue to have at the charity, a lot of questions about returning to work. Now that shielding has been paused, it's been paused everywhere. Now Wales paused its shielding on Sunday, so we now have the whole country with pausing in shielding. And I think it's reasonable perhaps for me to make a couple of comments here, just to say that everybody, we've had from a lot of people who are concerned about this, and one of the things that we advise and our advocacy officers would advise is that you speak to your employers well in advance before you go back to work, that you're entitled to a risk assessment with your employer, that some people have said when they have heard what the employer is going to be putting in place, they have felt reassured. And some people have said that they really do want to get back to work. But we also know that there are some people who, and many of us, who remain clinically extremely vulnerable, and that there has to be a conversation with your clinician about what that means to you and what mitigation can be put in place. The government has said that the preferences for the advice actually says work from home unless your place of work can be made COVID safe. And then the people that we are hearing from, the patients we're hearing from, are people particularly on the front line. We just raised that question about somebody who's a teacher who's on dialysis, and those are perhaps some of the more complex issues that I think it would be really helpful if Andrew was able to comment on those. And there's a particular one that perhaps we can kick off with there, which is, can dialysis patients go back to work before the country is in so-called phase 4? In other words, until we get to a different stage in the pandemic where perhaps we aren't at the moment. So over to you, Andrew.
So there's no magic answer here, because there are two elements to this. One is the job and the environment you will be returning to. How safe can it be made? Can you be able to undertake that with minimal risk of meeting other people and potentially acquiring COVID? Or indeed, could you still work from home? So there's the job and what's done on that side of the coin. And then there is you and what your risk is. And by and large, people on hemodialysis generally fall into the extremely vulnerable group. And ideally, if you are on hemodialysis, most of you, particularly if you've got other conditions such as diabetes, you've had cardiovascular problems, heart attack or a stroke or anything like that, you are at greater risk, and you should be working from home if at all possible. But that's not always the case. And so you therefore need to have that two-way discussion. And I think for hemodialysis patients, it's even more important to have the discussion with your nephrologist, who can advise you about your risk in the context of the job you are proposing to return to, and they can support you in relation to your discussions with your employer, as indeed can Kidney Care UK advocacy team. They can all provide you some advice. So there's no magic answer here, Fiona. It's about individualizing your risk to the job. And my advice for most dialysis patients would be, if you can continue to work from home, do so.
Okay, thank you. So there's a few questions that have come up, and a few that are still here as well. And some of these are about, so there's several people who are working in sort of quite supermarkets, or quite a lot of exposure to the public. So is there any particular thing you could advise there in terms of social distancing, or things that employers should be?
Well, the employers will need to find what roles they can offer these individuals that provides less direct customer contact. Clearly, they also need to be reassured, if they're working at a till, for instance, that there is a screen, that the till is cleaned down before they have come and sat down there. You know, those are the kind of things you can do to reduce your risk. So if the till and that seat is properly cleaned before you sit there, you're sitting there for a shift, you are have a means of managing things without direct contact with customers, that's probably safer than the old style till. So there's lots that can be done in the workplace. But still, you may take the view, I would like to do a backroom job rather than a front job, if at all possible.
So these are two opposite points actually that respond to that. So one person, their occupational health, said that they shouldn't go back, but they really want to, if they can keep themselves sanitized. And then somebody else said, would I be right to refuse to expose myself to an environment where there is no enforcement of masks or social distancing?
So first one, occupational health have assessed, given the context of the job and the patient, that you may be putting yourself at increased risk. On top of everything is individual choice. You may make that choice. You might want to discuss it with your nephrologist before you actually jump into that. The second individual, I certainly would recommend going to talk to your nephrologist about your risk, because it may be the employer and the occupational health team don't understand the context of hemodialysis patients. And indeed, let's be very clear, at the start of the pandemic, hemodialysis patients were not treated as a separate group who had high risk. And it was only as that became apparent did we move to a situation where we recognize the significant risk to hemodialysis patients.
Thank you. And without wishing to put a massive burden on all our kidney doctors, are you prepared to write letters or provide letters for
Oh,
employers to assist them with,
yeah,
so they can understand that?
I don't think this is a massive burden, because if you look at each dialysis unit with their consultant, how many people work, how many people are in this position, it's not going to be everyone. And in fact, I believe the Renal Association of BRS have very helpfully produced template letters that we can use to help us support patients in their decision making and inform occupational health.
Indeed, thank you. And that was the prompt for that. So, and we do have links for that on the Kidney Care UK coronavirus patient information resource, which is regularly updated with the latest that we can in terms of news. Other question, if I may. So are there any particular risks for people from BEME backgrounds, and do they differ between Black and South Asian people?
There is no question that Afro-Caribbean ethnicity carries the greatest risk, if you acquire COVID, of having a poorer outcome. The South Asian one, which has been recorded as being a greater risk, there's some interesting data coming from our review in London that suggests it's not quite as great as Afro-Caribbean. But I want to remind you, again, I said this at the beginning, I said this at the middle, and I'll keep saying this. The risk that you have is very much dependent on other attributes that go with your ethnicity. It isn't just your ethnicity. If you are an Afro-Caribbean dialysis patient who is, say, young, 40, has no diabetes, isn't on any immunosuppression, is otherwise fit, maybe competing in the transplant games or something, you know, really keeping yourself fit, you may actually have less risk than other hemodialysis patients. So you've really got to see that risk in the round, which is why discussing it with your consultant or your hemodialysis senior nursing team is in your interest.
Okay, thank you. And there's probably just one other in here, which is, and I think you addressed it earlier, but perhaps worth just mentioning again. And it's not so much about going back to work, it's more around if somebody gets COVID and they already have compromised kidneys, is it reasonable to say that it will, what impact will it have on their kidneys? How will it affect them further?
Well, the answer is that if you get COVID and you've got CKD, you may experience a period where your kidney function deteriorates. You should, if you recover from COVID, then see recovery of kidney function. What we're not certain of is there are a small proportion of patients who get that deterioration and don't quite make the full recovery, and are left with less kidney function at the end as to what they had at the beginning. Most, though, will recover their kidney function. A few may be left with some deterioration in kidney function. And of course, if you started with very low kidney function, i.e. you were thinking about going on dialysis in the next 6 months to a year, an acute bad COVID could be the thing that precipitates you onto dialysis.
Right, okay, thanks. And can we just go back to our teacher on dialysis? Was there anything in particular you'd be able to advise them in addition to anything you've said already?
Well, my daughter's a teacher, so I'm aware of the issues, and it would be lovely if you could carry on doing remote teaching. I know that most schools, there's a real drive to get things back and started. I think that you have to have a really serious discussion with your occupational health department. And with your school, because you need to ensure that the way you are undertaking your teaching is as secure as possible. And there are lots and lots of tricks that can be brought into the way you work to ensure that you are not mixing with lots of different students directly. There are ways of doing this where you can keep your distance, you can have a well-ventilated, that's not an internal ventilation, but a well-ventilated room. And you must do frequent hand washing, keeping your distance, watching what you do at break time and staff time, because it's those meetings that are important, and coming and going, of course, to school are also going to be important. So there's lots of ways you can reduce that risk, but the risk will always be there for you.
Indeed, and actually you've now just picked up on a question that we had live, which was about journeys to work and whether it's safe to travel by train or public transport to and from work.
Well, the answer is, of course, if you can go by your own means, go by your own means without public transport. I was, however, reflecting yesterday when I was in the car and I drove past 3 buses, all of which were completely empty. So if you can travel outside rush hour, if you have to travel public transport, this is the kind of discussion you have with your employers. You can say, I can only come in outside rush hour hours. I need to come in so that I know the buses or tubes will be relatively quiet so I can keep my distance. I'll be wearing a mask. I will not be touching things or hand sanitizing before I get on and when I get off. So there are ways you can reduce the risk, but I would not recommend you join the rush at 7 o'clock to 9 o'clock in the morning when tubes are full and you cannot avoid direct contact.
Very sound advice indeed. So yeah, thank you very much indeed. And there is just one other one that's come up, which we can address now. We knew this would be the main session, one of the biggest ones of this afternoon. Is the risk greater for hemo patients as opposed to PD patients in returning to work?
Actually, the answer is that the risk that you face is returning to work. The reason the PD patients got less infections than the hemo patients was that they were able to properly shield, whereas hemo patients, while they did shield, it was an artificial shield because they still had to come into dialysis units. And it took us a while, all that great work that Karen described, took us a while to build up to our knowledge of how we can best manage hemodialysis units. So the answer is that your risk is probably the same if you return to work to a hemodialysis patient, and you need to take the same precautions.
Thank you. Same risk, same precautions. Great. Now we're running along, and for people who may have joined slightly late, we said at the beginning that we would be prepared to continue for perhaps 10 or 15 minutes after the scheduled end time of this session, because we've had, as you've seen, quite a few live questions coming up. So that's great. Julie, could you click the next slide, please? Sorry, click the next slide button. So we've got the 4th question of this session to come up. And this one, we had a few questions earlier about vaccines and antibodies. And I wonder, I know this is your voice again, Andrew, but I wonder if we could ask you just to comment on that, because people were asking about live about those, and a number of people have also asked when will we be vaccinated, can we get an antibody test as people on the high risk list?
So the vaccine, we're all waiting for the vaccine. I hope it will be out there soon. I believe that hemodialysis patients will be offered the vaccine, but please be aware, hemodialysis patients aren't being included in the trials of the vaccine. And we need, once we've got the vaccine, to understand how effective the vaccine is in hemodialysis patients, because it may be that you don't mount the same response as someone who isn't on hemodialysis. So my advice would be, and you'll get this advice obviously from your unit when the vaccine comes out, to get vaccinated, but we will probably be monitoring you for the development of antibodies, whether you are at risk of COVID, after vaccination, to determine how frequently you need to be revaccinated. Don't forget, I need to put this in, get your flu vaccine early, as soon as you can. If they do that at the same time, brilliant. But if the vaccine isn't here till December, get your flu vaccine as soon as it comes in, because you don't want a double whammy. Antibody tests tell you not whether you have the disease, but whether you have had it. The problem is, even among people with normal kidney function, they are not reliable. Not everyone generates antibodies, even if they've had the disease. And if you're on hemodialysis, you are less likely to generate antibodies. So it's useful perhaps, but having a negative antibody doesn't mean you haven't had the disease. So we're doing a little bit more work before we understand the use of antibody testing in people on hemodialysis.
Okay, thank you. And perhaps could you just talk about why some patients might be asymptomatic? I heard that there had been quite a lot of testing in some units, and they'd found that people had COVID, but they'd been asymptomatic. And I wonder if you could illuminate a bit on that.
Well, this is the extraordinary nature of this disease, is that most people who get it don't get much in the way of symptomatology or get a very mild flu-like symptoms. And that is probably the case for the dialysis population, perhaps skewed more to getting sicker. So I suspect, and I don't know the data, that the asymptomatic patients are less if you look at 100 hemodialysis patients compared to 100 patients with normal kidney function. So this is just how the disease operates. We don't have an answer to your question as to why. We wish we did understand why person A will go on to have no symptoms and person B will have that really bad high temperatures, shortness of breath, and need respiratory support. We don't understand what differs. We do understand this is where the risk comes in, that if you have got one of those parameters I've described, you're more likely to move into that second group, but you may still have no symptoms. And we need to be cognizant of that.
So in a way, it's quite reassuring to hear, though, that many people have had it with virtually no symptoms and therefore come out okay, because that was something we were all not worried about, that everybody would have. We took a very, it's been a really difficult and tragic period on hemodialysis units in the UK, particularly in the areas that were badly hit over March and April. We've learned a lot, and I hope that we will never see that again, or be able to really look after our patients and prevent that happening again. But I think that there will still be a lot of people who will be able to avoid the infection, and there'll be a lot of people who will get lesser degrees of illness. There's one interesting piece of research which I think explains why we're seeing increasing cases around the world with less illness. So interesting, at Imperial, there are hardly any patients in the hospital now with COVID, even though there are still cases in the community. I think there's a story about the inoculation, and the amount of COVID you receive at that first exposure may be proportional to the subsequent illness you suffer. And because we're now all practicing safe distancing, washing our hands, being careful, not being in the same room as someone for long periods, I think our inoculations are much less, and people are getting lesser degrees of disease. Please, that is Frankel's theory, but we need to prove that. So a theory, but a very interesting and potentially quite an encouraging one. We've got another question that's just popped up from somebody who says, I've never suffered the flu. Should I really take the vaccination?
Well, I mean, Karen can answer this as well as me, probably. The answer is yes. If you're a dialysis patient, get vaccinated. You may not, I've never suffered from flu, but when I did suffer from flu, I can tell you, I don't want to suffer from flu again. And as a dialysis patient, please remember, it causes more harm year on year than COVID. Please remember, this is a very significant illness. Get vaccinated.
Thank you. Thanks a lot. And Julie, could you go on to the next slide, please? Because this is just a couple of other questions then. And perhaps you could, yeah, there we are. So we'll just leave it at that. So Karen, we've had a few questions that have come through by people sending them, and they came up on the question and answers as well, about to do with travel. And I know Becky Suckling has very kindly responded to many of those questions on the Q&A, which is fantastic. But would you be able to just give us a sort of a couple of things really? When will it be possible for dialysis patients to travel abroad? And if somebody is on home dialysis, should they consider travelling during this time?
Okay, thanks, Fiona. I think a lot of it's going to be about risk, isn't it? And thinking about where you want to go, looking at the destination. Is the risk high? Are you going to have to quarantine from that country if you come back? I think people are concerned about how safe is it to fly. I know that airlines are asking people to wear face coverings. Some airlines may be having more distance between the seats. I think it's very much about having the conversation with your kidney doctor, looking at your own personal risk. and thinking about, is it the right time to go abroad at the moment? Because we know we've just had France in the last few days, and now having to quarantine. Things are changing so constantly. And I think it's weighing up, and I think there's a lot of information around dialysis away from base. There is a document from the British Renal Society and the Renal Association looking at recommendations for dialysis away from base. I think considering where you're going, and also we know when people have been abroad or even dialysing in another unit in the UK, they are coming back, and we do isolate them when they dialyse just for precaution, so that wouldn't change. So I think there's quite a lot of factors there. I don't think we can say, yes, you can grow abroad, no, you can't grow abroad. I think it's very much about looking at the individual and the risk and considering where you're going.
Yeah, thank you. I know there's that new guidance, but as you say, I don't think we're perhaps in a place to do that, certainly in this country at the moment.
No.
Would that be fair to say, whether going to another country is possible or even practical right now? So as we move along to the final one or two questions, really, before we finish, I think there's a couple of things here that perhaps either of you to answer that have come up. So one's about, are there any limitations to doing dialysis exercise in a dialysis unit at this time? Some people do dialysis exercise, don't they? Mm-hmm. So Karen, that might be you actually.
Yeah, I think it depends on the type of exercise, doesn't it? And I think it's, I think if you're looking at people going back and going to gyms and things, they're doing things differently. I think there's some discussion. I know the renal rehab group are looking at this particularly to see whether there is if you could do certain types of exercise. I think we've got to be mindful that if we're talking about, I suppose, aerobic exercise where people are breathing and getting very exhausted, but probably on dialysis you're looking about a bit of gentle cycling or something, so it might be that's potentially okay. I think it depends on the environment and the unit and what the unit's already got in place. So it's probably something to have a discussion with the local team or the therapies team that are providing exercise on dialysis to see if that's actually feasible at the moment.
Right, but anyone who's doing any absolutely not that likely, but some really mega exercise that could be challenging. Okay, lovely, thank you. And Andrew, I didn't see it come up, but somebody was asking a question about needing to shield. So on the just before a transplant, so somebody on dialysis, so they're having a live transplant. I think it's a live donation. What would your advice be about shielding or self-isolation or whatever it might be at this time?
I think most units will have a policy and will be informing patients who are due for live donors who are on dialysis. They'll be telling them exactly what they need to do. So I'd be very surprised if your unit doesn't tell you this. Generally, you should. The word shield has got a very particular meaning. You should self-isolate, you should minimize your contact with anyone external to your household, and you should ask your household if they are traveling around to be mindful of your needs for at least the 2 weeks before, but you still have to come into dialysis. And when you go into dialysis, your dialysis unit may treat you differently to try and protect you, to ensure that when you go in for your transplant, there is less of a likelihood of you carrying COVID and thereby causing the transplant to be delayed.
Okay, thank you. And what about your children? So if you have children at school, what do they do in that situation?
I think that they still go to school, but every single thing that Karen mentioned that you do, you reinforce. So you may have less contact with your family in that 2 weeks if it is possible. And it's very easy for me to say this, but many families, it's not easy to do that. You're just going to have to minimize your risk. I think that no one will expect you to go and live alone in a complete bubble and forget the fact that you are part of a family before a transplant, but they will expect you to have taken action as best as possible to minimize that risk of potentially acquiring COVID.
Thanks, that's really helpful. I just didn't see the question come up, but I think it was a great question, and perhaps hopefully helpful to some of the people who have kindly stayed on as we finish the session. And I just wanted to do a quick reminder about our patient information, which will reflect some of the latest guidance as these things twist and turn as we go through, that we do have a couple of counsellors, Dee and Jackie. If people have any particular emotional things they would like to discuss, we can help if you're not able to get that help or you'd like to get that help from us as opposed to locally from your unit. And as Andrew said earlier, in terms of employment or signposting support, the advocacy officers are available for you to help as well. I expect you've all seen this social distancing little shield there, which is the badge. There are badges, the NKF does a lanyard as well. So there are various things people can use to indicate that they wish to keep a social distance. So what I'd like to do then, unless there are any other open questions, no, I can't see it. Oh, there's one actually. It's about somebody needing a stent. Should anybody, that'll be the last one, thanks. Should people isolate if they're going to have surgery? That's basically the question.
Again, I would expect, I mean, Karen's practice is, trust is different. They will be getting advice before they come into surgery as exactly what they should be doing. And it is all about reducing your risk of acquiring COVID and requiring you to actually cancel the operation. And trusts are developing really complex ways to ensure that people go through either COVID-free pathways, COVID or COVID risk pathways, and they will be telling you which pathway you're going under and how to reduce that risk of acquiring COVID prior to your surgery. We've got to get on and do all these things. We can't hold medical care up, because otherwise the harm that will cause will be greater than the harm that we have from COVID.
Thank you. That's fantastic. So I'd like to give a huge thank you to the both of you, so nurse consultant Karen Jenkins and Dr. Andrew Frankel, for being so patient and going through all of these questions this afternoon, and also to Dr. Rebecca Suckling, who has been kindly responding on the Q&A, which has been really, really helpful. If you have other questions, personal medical questions, obviously you do need to keep talking to your kidney team. If you want to order that distance aware badge, we are giving them away, so you can go onto the website and have a look at that. And if you are tweeters, if you put in hashtag distance aware, the little badge, that little symbol comes up. We're all very excited about that, because it means Twitter are supporting everybody, not just kidney patients, who wants to keep a social distance. So we'll be writing up a report about the questions and answers that came through this afternoon. Just a brief summary. There'll be a link published, so you can have a look at this talk again and listen to it if you would like to do that. And we'll also be, I hope you'll be fine with that, sending you a very brief follow-up survey in due course. And because this session was our dialysis question time on COVID, we're looking to do another one for people with transplants. So I know we had quite a lot of transplant-related questions for this one. So we'll be looking to do one of those in September, and we'll let you know about that in due course. So I think it remains for me, unless any of my colleagues have anything they'd like to add in, to thank everybody and just make sure I haven't forgotten anything. I don't think so. And so thank you all very much from all of us at Kidney Care UK, and from the Renal Association, the British Renal Society, and the Association of Nephrology Nurses.
Thank you, Fiona.
Thanks a lot then. Thanks everybody. Bye-bye.